using her walker. She has hypertension, heart failure, and rheumatoid arthritis. Medications: lisinopril, furosemide, ibuprofen for joint pain. Temperature is it's normal. Pulse is normal. Respiration normal. BP a bit low. Mucous membranes are dry. Cardiopulmonary exam is fine. Neurology exam is fine. Mental status exam, she's not oriented to place or time. Serum uh, serum studies. Sodium is high, potassium is high, chloride is high, bicarb is high, urea is high, creatinine, everything is high. Analysis and check says ratios no abnormality. Which of the following is the most appropriate next step?
Okay, so IV administration of the 0.9% sodium chloride. So inadequate free water intake leads to dehydration and a variety of electrolyte disturbance, including hypernatremia, which is defined as serum sodium greater than 145 milliequivalent per liter. Under normal circumstances, increase in serum osmolarity are detected by hypothalamus, resulting in increased secretion of vasopressin and increased thirst, resulting in the retention of free water in the kidneys and in increased water intake respectively. Hypernatremia occurs most often in elderly patients, typically during an acute illness mobility where mobility and excess of water may be impaired, or where altered mental status or impaired thirst response may limit water intake. Hypernatremia may also occur in the setting of a variety of conditions that cause loss of both free water and electrolytes, and resulting in hypotonic fluid loss, such as in the setting of diuretic use, severe diarrhea or nasogastric suctioning, or gastrointestinal fluid drains. Patients typically present with altered mental status and clinical evidence of volume depletion, tachycardia, hypotension, orthostasis, poor skin turgor, dry mucous membrane. The diagnosis is established with serum chemistry, which can also identify other electrolyte abnormalities. Evaluation for underlying infections that may have precipitated the episodes, such as with chest x-ray and urine analysis, is important. Given this most negative infectious workup, it is likely that her symptoms were caused by physical debilitation, limited her access to water, exacerbated by the use of furosemide. Results of lab study shows hypernatremia. Hyperkalemia, hyperchloremia, alkalosis, and increased serum urea, nitrogen, and creatinine concentration consistent with the volume contraction and prerenal azotemia. Treatment with correction of volume depletion, isotonic crystalline infusion of 0.9% saline, which contain 154 milliequivalent of sodium, is preferable, as this will correct volume depletion while causing minimal risk for overlay rapid correction of hypernatremia. The rate of correction is dependent on the suspected duration of the hypernatremia. Acute hypernatremia of less than 24 hours of duration can be corrected rapidly, while more chronic hypernatremia should be corrected slowly at a maximum rate of 10 milliequivalent per day to avoid cerebral edema. So how will we correct? Like giving 0.9% sodium chloride.
9% sodium chloride.
That means isotonic fluid.
Yeah, just isotonic. No 9%. No 9%. It
Point. Sorry.
just normal isotonic fluid that doesn't have that much sodium and doesn't have that much water. Just normal one.
Okay.
That's does that make sense?
I'm not getting why we are giving this.
Okay, so which one would you like? Which what was the other answer that you were thinking of? Be- Like in all these
Like
other.
we
Mhm,
can give this option C. Okay, I'm
mhm,
intravenous administration of 5% dextrose in water is useful for volume correction, but becomes hypotonic as the infused dextrose is metabolized. Infusion of hypotonic saline increases the risk for overly rapid sodium correction, which may lead to cerebral edema. In patients with unknown nutritional status, infusion of 5% dextrose in water may lead to refeeding syndrome and variety of secondary electrolyte abnormalities. These patients' sodium is way above, like
mhm,
uh, more than 10 milliequivalent more than the normal. So why
mhm.
we are not giving the hypotonic saline for maintaining the tonicity? That's my question.
Oh, this is what they told you here. If you give hypotonic, you correct it too fast, and
Then
then. Mhm,
then it may cause cerebral edema. Okay,
mhm,
it is the normal way of sodium correction. Like if we correct rapidly, like if we correct more than 10 milliequivalent, 10 to 12 milliequivalent per day,
mhm,
it may cause pontine myelinolysis or it may cause
mhm,
cerebral edema. So this
mhm.
is the normal rule of the sodium corrections. But
Yeah.
it is that rule is for hyponatremia. Is this for hypernatremia also?
It seems like it. I don't have my notes for, but it seems like it. I usually just do the isotonic.
Like everywhere, if there is
Mhm.
sodium correction, then we will give the isotonic fluid.
I know there are places where you give straight. I'm gonna check my notes, but I know if the patient is unstable or something like that, you give straight. You can do the hypotonic thing, but I don't remember the rules. I just don't remember where were the rules for that. But in case I don't know, I usually just give the isotonic solution
Okay,
straight up. I just don't. I'm gonna check my notes on that
okay.
one. Yeah.
Next.
28 woman comes to the physician for follow-up exam 6 months after discharge from the inpatient psych unit, where she was diagnosed with bipolar disorder. During hospitalization, lithium carbonate and quetiapine therapy was begun. Since the start, she has been in regular outpatient psychotherapy and has been complying with her meds. Today, she reports 1 month history of frequent urination and mass sedation. She says her mood has been stable since the start. She has no other serious illness, appears alert. Physical exam shows an intention tremor of the upper extremity. Mental status exam shows, I guess, normal mood. Speech, language, and thought process are normal. In addition to measurement of the spatial and lithium concentration, which of the following is the most appropriate next step?
Okay. So it's serum measurement of fasting glucose and thyroid hormone creatine concentration.
Hmm.
Okay. Lithium is a mood stabilizer. Lithium is a mood stabilizing medication commonly utilized to treat acute mania as maintenance treatment in this patient with bipolar disorder the recurrence of manic to prevent the recurrence of manic or depressive episode. At therapeutic doses, lithium can cause a variety of side effects, including sedation, tremor, nystagmus, nephrogenic diabetes insipidus, thyroid dysfunction. Typically presents Lithium-related tremor typically presents with mild mild symmetric intention tremor of the upper extremities. As seen in this patient, polyuria is common in patients with lithium. Polyuria is common in patients with lithium. The most common cause of are nephrogenic diabetes insipidus. Primary polydipsia through lithium may also affect glucose metabolism, necessitating measurement of these patients' blood fasting glucose concentration. Measurement of patients' blood fasting glucose concentration in NDI in nephrogenic diabetes insipidus to resistance to antidiuretic hormone leads to decreased free water reabsorption from collecting tubules, resulting in polyuria along with the state of dehydration and hypernatremia. And increases in creatinine may occur, can also indicate CKD, a lithium side effect that typically occurs after years of use. As such, TSH serum creatinine concentration are routinely measured in patients on lithium. Okay.
Okay. Next, 62 woman comes to the physician for follow-up exam. She was discharged from the hospital 7 days ago after treatment for left iliofemoral venous thrombosis. Iliofemoral. Okay. Pain and swelling of the lower extremity was successfully controlled with heparin and warfarin. The heparin was discontinued on discharge, but only medication is warfarin. Exam of the left breast shows erythematous area with patches of purple to black skin. Okay, which of the following is the most appropriate next step in management?
Is it warfarin in skin necrosis?
I guess, yeah.
Okay.
Mhm.
So this patient's presentation. So this patient has a presentation consistent with warfarin-induced skin necrosis. Warfarin is an anticoagulant that inhibits the hepatic synthesis of factor 2, 7, 9, 10, in addition to protein C and S. This occurs through the inhibition of vitamin K epoxide reductase, which is necessary for recycling vitamin K, an essential cofactor in the synthesis of coagulation factor in the liver. Since protein C has shorter half-life, since protein C has shorter lifespan than other aforementioned factors, it is depleted first, leading to a transplant procoagulant state in patients initiated on warfarin therapy. This is not usually of clinical significance but rarely may lead to warfarin-induced skin necrosis. This is typically true. This is typically true if the patient has a pre-existing protein C deficiency. Warfarin-induced skin necrosis can present with demarcated areas of purpura and necrosis resulting from vascular occlusion. These usually occurs in the these usually occurs within the first few days of warfarin administration if breaching with heparin. If breaching with heparin may appear when heparin is discontinued. If heparin-induced skin necrosis is suspected, the warf if heparin if warfarin-induced skin necrosis is suspected, then the warfarin should be stopped. Then the warfarin should be stopped immediately with vitamin K for warfarin reversal and FFP for warfarin reversal and F fresh frozen plasma as a source of protein C to prevent progression of the necrosis. Patients should be started on different anticoagulant medication for treatment of their underlying problems. Okay,
Okay. Oh, let me show you what I found.
sorry.
Let me show you what I found. This is the
Okay,
hypernatremia thing.
okay.
Uh-huh.
If
The
it is
member,
euvolemic,
uh-huh.
then 5% dextrose. So euvolemic, then how will we calculate the volume? Like why it is called euvolemic, why hypervolemic?
I think it's just the BP, right? Like, and then you see in that patient, they told us that she had dry mucous membrane, the BP was low, so they are giving you
BP was
symptomatic.
not that low, 100/80, isn't it?
What is it? Which one was it? Is it this one? But yeah, but they
Yes,
told you,
yes,
yeah,
mucous membrane is dry.
yeah. So they give you. I don't think they give
It is hypovolemic
hypovolemic and then
symptomatic.
symptomatic. I think because they
That patient is tachycardic.
let me see. No, she wasn't really tachycardia, but you see, it says tachycardia, decreased
Yes,
BP, dry
dry
mucous
mucous
membrane.
membrane.
Yeah, and she had the dry mucous membrane.
She had. So
Yeah,
that's why we are giving isotonic fluid.
yeah. So I guess we are only giving normal fluid, the
Uh,
5% dextrose one, the hypotonic when she's euvolemic, so she has normal feeling,
asymptomatic.
or asymptomatic, I guess.
Very complex.
Yeah, it's kind of complex. And then that's the hyponatremia one. That one is, yeah, something else. Yeah.
Okay,
Yeah.
so I got it. So this box is important, which you found.
Mm.
I have seen plenty of time, but I have not
Yeah,
seen in that way.
yeah, yeah, that's true. Okay, previously healthy 22 woman comes to the physician because of a 3-week history of intermittent episode of stabbing pain in her right lower abdomen. Each episode lasts up to 2 hours. The most recent episode awakened her from sleep. She's currently in no pain. Menses occur at regular 28 days interval. Her last menstrual period was 2 weeks ago. Lasted 5 days. She's sexually active with one male partner and uses condoms consistently. Temperature is fine. Pulse is fine. Respiration fine. BP a bit low. Fine, I guess. Exam of the abdomen shows no tenderness or distension. There is 6 centimeters mobile right agnatosome mass anterior to the uterus. Test of the stool for occult blood is negative. Hemoglobin is, I don't know, I guess normal. Leukocyte count normal. Platelet normal. Urine pregnancy test negative. Let me check the hemoglobin. Hemoglobin female a bit low. Low normal. Pregnancy pelvic ultrasound shows a partially cystic mass in the right ovary with a single echogenic nodule and decreased
You need to like memorize uh, some of the lab values.
lab dry. I,
Yes,
yeah, that is true.
because
Let me show.
if you uh, just start watching in all the questions, then uh, your time will be hampered.
Mm-hmm.
as we are doing now, so it's not, it is not because of me. Like I am not, because whenever you start seeing the lab value, every time it helps, as because I start taking
Mm-hmm.
also.
Mm-hmm.
Because I don't know all the lab values also, but we need to remember some of the lab value to save our time.
To save time, that's true.
Yes, yes.
That's true. I feel like during the exam where I just kept the lab thing open at some point. I was just like I just kept it open because I was like I'm tired of keep opening. Let me just keep it open.
Is it possible to keep open all the time?
Um, yeah,
May not be,
I think I remember.
because
Maybe.
this is the nbme one and this is the actual exam one, isn't it? If you want to see the
Mm-hmm.
lab value, then you need to open it, but you
Let me
cannot
see.
keep it in the site.
Because you see, like when I move from one question to the other, if it was open, I feel like you see it's still open.
Oh, okay, okay.
I think so. I'm not
But
sure.
your vision will be problematic.
That's true. Yeah, yeah, that's true.
Okay,
Okay.
okay, okay. I'm reading the explanation.
Mm-hmm.
Okay. So it's ovarian cystectomy. This patient with intermittent severe abdominal pain in the setting of large heterogeneous cystic ovarian mass is most likely having intermittent ovarian torsion caused by a large mature cystic teratoma, which should be treated with ovarian cystectomy to prevent which should be treated with ovarian cystectomy to prevent further episodes. Ovarian torsion is caused by twisting of the ovary, uh, about its ligamentous attachment, with a resulting compromise of its blood supply, leading to ovarian ischemia and eventual necrosis. Patients presents with a sharp, severe patient presents with sharp, severe unilateral lower abdominal or pelvic pain, often accompanied by nausea or vomiting, while ovarian torsion can occur spontaneously and resolve spontaneously. The risk the risk is increased in the setting of large ovarian cyst more than 6 centimeter mature cystic teratoma, as seen in this patient. Mature cystic teratoma are benign tumors of the ovary. They contain tissue derived from all three germ layers. As a result, contain differentiated structures such as hair, bone, teeth. Physical examination typically discloses a unilateral adnexal mass of pelvic examination, unilateral adnexal mass on pelvic examination, which may be tender. Ultrasonography will show a complex cystic adnexal mass with internal echoes, as seen in this patient. Okay.
Can you read A, B, and E?
Yes. Measurement of serum serum Ca-125 concentration is used in the evaluation of cystic ovarian cancer. Evaluation of sorry ovarian cancer, which most commonly presents indolently with abdominal distension, early satiety, and weight loss in the postmenopausal patient. Risk factors include family history, genetic mutation, BRCA, increased age, smoking, nulliparity, and pelvic radiation. Physical examination may disclose a palpable adnexal mass, and ultrasonographic features seen include septation, cystic components, increased blood flow, heterogeneous structure. Ovarian cancer would be unlikely a patient would be unlikely in a patient this young, and the echogenic component of her ovarian mass with decreased blood flow makes it more consistent makes it more consistent in makes it more consistent, show a more consistent with a mature cystic teratoma. C. Ultrasonography of
B,
ultrasono sorry
B
B.
and E. Mm-hmm.
Okay, uh, OCP is commonly used in the treatment of a variety of gynecological issues such as oligomenorrhea and recurrent physiologic cysts. The latter refers to simple cystic structure of the ovary that occurs during the process of a follicle development when an egg is not appropriately released from the follicle during ovulation. If the cyst becomes large or ruptures, it can cause severe unilateral abdominal pain. However, it would be seen as a simple cystic structure on ultrasonography rather than a complex mass seen in this patient. And right salpingo-oophorectomy or removal of the right ovary and fallopian tube. Removal of the right ovary and the fallopian tube may be used in the treatment or prevention of ovarian cancer or recurrent ovarian cysts the patient given the ovary's contribution to the given the ovary's contribution to appropriate hormone balance in the premenopausal patient. Surgical oophorectomy is avoided if possible. Additionally, this patient is young and removing an ovary would increase her risk for infertility. Thus, an ovarian cystectomy would be the more appropriate next step in the management of this patient. Okay.
Okay. 37 women gravida 2 para 2 comes to the physician for routine health maintenance. Menses occur at regular 28 days interval. Routine pap smear has shown no abnormality. No history of serious illness. Mother had breast cancer at 63. Maternal aunt had endometrial cancer at 54. And a paternal grandmother had colon cancer at 72. Patient is sexually active and monogamous with her husband. It has been using OCP for 8 years. She doesn't smoke cigarettes or drink alcohol. Her children are 9 and 11. She works as a nurse. Physical exam, including breast and pelvic exam, are fine. She's concerned about the history of cancer in her family and asked about the screening test for cancer. Which of the following is the most appropriate recommendation at this visit?
Okay. So no screening is indicated. Screening tests are used to identify potentially Screening tests are identified to potentially treatable condition early in the course to prevent long-term morbidity or mortality. Cancer screening are an important item of discussion at health maintenance examination. The decision to perform screening tests for malignancy The decision to perform screening tests for malignancy is based on the age of the patient and whether they have increased risk for any specific cancer. Screening tests also decrease in value the more often they are performed. In this case, this asymptomatic patient will not benefit from mammography at this time because she has no identified breast mass and routine screening is not indicated until age 40 years depending on the guideline followed. If there is significant concern of genetic cancer predisposition, additional testing of BRCA can be pursued. Ovarian cancer is not routinely screened unless there are concerning related signs and symptoms, which is concerned case findings. Instead, other non-malignant conditions for which screening tests are helpful is hypertension, hyperlipidemia, diabetes, osteoporosis. Colon cancer screening will eventually be indicated for a patient as well, but not until age 45.
You rate D.
Okay, so colon cancer screening start with the 45. We know that,
Mm-hmm.
and like BRCA testing when it is started. Is there any timeline?
BMC what? I couldn't hear
BR
you.
BRCA
Uh-huh.
testing like
Uh-huh.
breast cancer.
Uh-huh.
So is there any time like if it
No, I don't like, is there an age? That's that what you mean? If there is a
yes
specific
when BRCA okay I am reading.
mm-hmm.
Okay, you said what option?
D
Okay,
as in
D.
dog.
Okay. So testing for BRCA mutation is not routinely indicated while this patient has a family history of positive breast cancer. It is not in high risk age range and does not have implication of BRCA involvement. If this patient has additional family members with breast cancer, then this may be though the decision to screen BRCA prophylactically in individual. So only one family member is involved. That's why we are not doing the BRCA.
She has two, the mom and the aunt. But I think there was one question that we saw. I don't know if it was here. They were saying that you do the BRCA ones when the family members had the breast cancer.
This patient's family member had the breast cancer. Her
Yeah,
mother had the breast cancer.
yeah. But that question was saying that
Her
if
mother, her aunt has endometrial cancer.
uh,
So
yeah.
if two family member had breast cancer, then a BRCA need to be done. Is
But there
this
was one question that we found, and it was saying that if they have it before they are postmenopausal. So if they have it before 50. Remember, there was one question that we found. I don't remember if it was
these
here.
questions are a bit confusing because when I see the BRCA mutation, I start thinking about Angelina Jolie.
Oh Lord.
Trust me, I have some problems.
But
So
yeah, I
I
think
like when I see the patient with SLE, I start thinking about. Do you know who she is?
oh,
Selena Gomez.
Selena. Oh, she has lupus.
Yes.
Oh, I didn't know.
It's Selena or maybe Selena Gomez.
Oh, I didn't know.
Like the girlfriend of the young singer. I
Um,
forgot.
I don't remember. Uh, but yeah, there was one question that we found, and it was like, oh, if they have it before 50, if the family members had it before 50. I think that's how I found this.
Okay.
We saw it in one question. I don't remember which one it was, but yeah, yeah. Mm, I can in a circle it, but I don't think there
Yes,
is.
I am right. Selena Gomez has, and she had done kidney transplant.
Oh, Selena Gomez.
Yes, she had done kidney transplant, and this kidney was given by one of her fan.
Hmm, hmm,
Okay.
okay. Here no, it doesn't say it. It doesn't say the family member, but okay. Never
Because
mind.
as far I know about the Angelina Jolie, she had done prophylactic mastectomy.
Yeah.
So she had done prophylactic mastectomy after BRCA positive, as far
Mm-hmm.
I know.
Mm-hmm.
So
Mm-hmm.
then when she had done BRCA, that is my question. So uh, like when we need to do the BRCA testing, that is my query. like when to start. Like if you want to tell a patient that you need to do BRCA testing, then when the timeline, that is the question. Okay.
Mm, yeah, no, I don't. I just remember that question, and they had said, yeah, if you have like two or more family members that had breast cancer before they were 50 or something like that. But it was that specific question. I don't know if it's, you know, yeah.
Okay, we need to find out these problems. We need to solve these problems before sitting in the exam, like when
Mm-hmm.
we need to do the, like, this, because this is very confusing question.
Mm-hmm.
Okay, next we'll find any solution.
Okay. 58
Oh,
men
okay,
returned.
like one one question you will find in the exam, like in every, like in every nbme, not every nbme, like I have observed like 2 3 nbme hypertrophic, like hukum, one of the question of hukum come in the exam.
Mm-hmm.
So there are some pattern, like there are some topics, we need to find out that this topic we need to be master on those topics. Got my point?
Mm-hmm.
Okay, if you find any topic, like you found that this is very important, we need to see that, you tell me.
Mm-hmm.
Okay.
Next, 58 men returns to clinic for follow-up 2 weeks after an initial acute episode of severe pain in his right great toe that prevented him from bearing weight on the toe and wearing shoes. He has had no, he has not had similar pain prior to that episode. At his initial visit 2 weeks ago, naproxen was started. Today, he reports resolution of the symptom. Medical history is significant for hypertension, hypertriglyceridemia. Medications: lisinopril, lovastatin, aspirin. The patient works as a fisherman harvesting shrimp, and he frequently eats some of the shrimp he's caught. He drinks 2 to 3 12-ounce beer nightly. He doesn't smoke cigarettes. BMI is high, vital signs or BP is high. It's the only thing that's high. Physical exam shows slight redness of the right great toe with no swelling or pain. Results of lab studies obtained 3 months ago during a routine health exam shows creatinine normal, glucose I guess normal, cholesterol. mm, Where am I? Cholesterol normal. Yeah. HDL normal, LDL normal. Triglycerides super high. In addition to recommended decreased alcohol consumption, which of the following is the most appropriate next step in management?
So recommend a low purine diet. So what is your diagnosis?
I thought it was gout,
Yes, in
but what
gout,
did it answer him?
purine causes more urea to produce. That's why in gout we tell the patient no, recommend a low purine diet. Okay, gout is an acute monoarticular arthropathy resulting from an intra-articular inflammatory reaction uh, due to precipitation of monosodium urate monohydrate crystal within the joint space. This can result from overproduction of uric acid. This can result in overproduction of the uric acid, but more commonly occurs following the under-excretion of the uric acid. Gout typically presents with acute atraumatic single joint pain, erythema, and swelling, which can recur in patients that are under or untreated. Polyarticular presentations are possible. Risk factors include a purine-rich diet and alcohol use. The most common joint is involved is the first metacarpophalangeal, but other Common joints include elbows and the knees. Excess serum monosodium urate crystals may also precipitate in the tissue as tophi, where it appears as yellow subdermal inclusion and masses. Arthrocentesis generally shows leukocyte count 10,000 to 50,000 and negatively bifringent needle-shaped crystals as seen in the photomicrograph of the synovial fluid. Early in the disease course, initial management include lifestyle modification, avoiding purine-rich meals, and heavy alcohol use. Treatment consists of non-steroidal anti-inflammatory drugs, colchicine, and corticosteroid for acute exacerbation. Chronic preventive management involves the use of xanthine oxidase inhibitors such as allopurinol. Okay.
So because it's his first gout attack, that's why we start with lifestyle modification. We don't give him allopurinol yet.
Yes. Allopurinol, before giving allopurinol, recurrent gout or presence of tophi, there are some criteria for giving allopurinol, like recurrent attack or
Okay.
like presence of tophi. These are the things when
No.
you need to give allopurinol. We do
Okay.
not give allopurinol after the diagnosis, after the first diagnosis.
Okay. Got it. 62 men comes to physician because of a 6-month history of mid back pain, numbness, and swelling in his legs and fatigue. He has 2 week history of swelling of his face and hands. Vital signs normal. Exam of the lower thoracic spine shows tenderness to percussion. There is 3 plus edema of the face, hand, and lower extremities.
Like urate lowering therapy, like allopurinol or febuxostat, it is given when there is frequent or severe attacks. Tophi, evidence of joint damage from gouty arthritis. If you see the evidence of joint damage, then we can give the allopurinol.
Okay,
Okay.
got it. Um, oh, 62 men comes to the physician because of a 6-month history of mid back pain, numbness,
And
and swelling.
one thing I
Mhm,
want to add, like shellfish, like your seafood,
mhm.
shellfish, and red and organ meat. These contains high purine rich. These are the high purine rich food.
High protein rich foods. Yeah.
Okay.
Yeah. Yep. I know I'm gonna end up getting gout because my dad has gout and I love seafood. It's my favorite food. So yeah, probably gonna end up having it. Anyway, the 2 men comes to the physician because of a 6-month history of mid back pain, numbness and swelling of the leg and fatigue. He has 2 week history of swelling of his face and hands. Vital sign normal. Exam of the lower thoracic spine shows tenderness to percussion. 3 plus edema of the face, hands, and lower extremities. Sensation to light touch and pink breath, whatever. Decrease over the lower extremities. Serum creatinine is high. Serum protein electrophoresis shows monoclonal gammopathy. X-ray of the lower X-ray of the thoracic spine shows lytic lesions in the vertebra. Urinalysis is most likely to show which of the following set of findings.
So it is multiple myeloma. Multiple myeloma is a malignancy caused by neoplastic proliferation of the plasma cell. Neoplastic plasma cells overproduce monoclonal immunoglobulin and light and heavy chains, which may result in acute kidney failure. Multiple myeloma can also result in Multiple myeloma can also result in primary amyloidosis due to overproduction and deposition of immunoglobulin chains in the brain, heart, kidney, and other organs. Kidney amyloid deposition on examination Kidney amyloid deposition on examination of a biopsy specimen shows deposits in the mesenterium, overproduction of immunoglobulin and light or heavy chains as well as kidney amyloid deposition leads to nephrotic syndrome or nephrotic range proteinuria because of the damage because of the damage to the glomerular filtration barrier. Large proteins such as albumin as well as plasma lipid are filtered into the urine. Urine analysis will show proteinuria and the presence of oval fat bodies, which is most likely in these patients classically seen edema, foamy, dark colored urine, hypoalbuminemia, and proteinuria. Can you explain the
No, I
like?
got it.
Sorry,
I got I got it wrong. No, I cannot explain it.
I have never seen multiple myeloma with such feature.
Yeah,
Because
me too.
multiple myeloma, most of the question there is hypercalcemia, there is
Exactly.
kidney problem, there may be anemia, and okay, that's it. An oval fat body, where it found? I
Well,
have never seen oval fat body.
that's true. Like, remember we read something about the different cast. Okay, no. So there is not the
No,
cast.
that is not present.
Yeah, it's not the cast. Okay. Yeah, okay, I don't know. I really don't know that one.
I try to remember, but how the 4 plus protein? Why is that? Is this
Okay,
because of nephrotic range proteinuria,
first,
like
yeah,
nephrotic syndrome?
yeah. So that part I can remember. I guess multiple myeloma causes nephrotic range syndrome. Okay, fine. That we can get it from there. But like the oval fat bodies part, I guess we just have to memorize that is specific for multiple myeloma, or is it that you can find it somewhere else? Like,
Fat body, like fatty cast,
because it's
is
not
present
fatty
in.
cast.
Sorry,
It's not fatty
fatty
cast.
cast. Okay, yes, no
Because
cast.
you see cast is here. No,
Uh,
it's not a fatty cast. It just says like a microscopic. I don't know. So I'm wondering if it's just like something that's specific for multiple myeloma.
don't know. I haven't found.
No, I cannot even find it on inner circle. Anyway, yeah, I guess it's specific for it. Okay,
Okay, next.
next. Just remember, multiple myeloma. You can find all fat bodies.
Oval fat bodies. Yes.
Clinical trial is conducted of a new drug, Elotin coronary artery stent. So new drug.
And another thing,
Mm-hmm.
do you remember that in multiple myeloma there is one gap, like elevated protein gap,
Uh-huh.
like total protein minus serum albumin. If it is more than 4 milligram per deciliter, it
Mm-hmm.
is uh, multiple myeloma, elevated protein gap.
Mm-hmm.
Okay. And in serum protein electrophoresis, we get the M protein, and on urine analysis, there is Bain-Jones protein. And
Mm-hmm.
in multiple myeloma, there is sometimes there is waxy laminated urinary cast is present. So
What's denominated?
waxy
Okay.
laminated cast. Okay.
Okay. Okay. Jesus. Clinical trial is conducted on a new drug-eluting coronary artery stent that does not require antiplatelet therapy for patency. In animal models, 20 patients who had NSTEMI are recruited to participate in the study. All patients have absolute contraindications for chronic anticoagulation and are not surgical candidates. This study design is most appropriate for evaluating which of the following. Wait, okay,
Okay.
okay, let's read it.
Safety.
Okay.
Okay. I don't know how I got right, but I got right. Okay. Novel treatments undergo rigorous testing prior to introduction of the clinical practice. The clinical trial describes in the scenario is characteristics. Phase a clinical trial are typically the first novel human subjects following prior to preclinical research, often involving in vitro studies and animal models. Phase 1 clinical trials are primarily Phase 1 clinical trials are primarily designed to assess of a treatment rather than efficacy. Involves small numbers of subjects because a small number of subjects are enrolled. Phase A1 trial mm, are provided to detect common and major safety issue and are not powered to detect the rare adverse event. Okay, phase A. Do you remember about what like phase o, A 1, 2, 3, 4 what
No, I don't
is
remember. I know I used to differentiate it by the number of patients that were, but I don't remember what was.
like 0, 10, 100 this. Okay, look at this box. It will
Are you
mm, uh,
sharing?
yes.
Mhm.
Can you see my screen
No, not yet.
now?
No. Yeah, no.
Like phase 0, like remember I swim. Can I swim? But I can't swim. Okay,
No, sorry.
can I swim? Okay. Phase 0 is initial pharmacokinetic and pharmacodynamic assessment via microdosing. So sorry.
No, I didn't say anything.
So in phase 0, like pharmacokinetic and pharmacodynamic assessment is done. And we know that very small number z- like 0, 10, 100,000 like that. As far as I remember, do you know the number?
No, I just remember. Yeah, it usually. I just know it's a small number, but I don't know like
Okay, very
specific.
small number. Then
Okay.
initial pharmacokinetic and pharmacodynamic. And phase 1, like our question stems. So phase 1, there is safety assessment via dose escalation and determine the maximum tolerable dose. So safety assessment via dose escalation. And in phase 2, uh, can I swim? Does it work? Like efficacy assessment. Does it work and provides additional data on short-term adverse effect. And in phase 3, any improvement like effectiveness assessment via comparison with current standard care or placebo, large number. And in here, like in phase 2 and in phase 3, there is randomized control uh, and anonymized. So randomized controlled and anonymized. I don't know it. What does anonymized mean? Okay. And the phase 4 provides data on long-term or rare adverse effect. Can I stay on the market? Post-marketing surveillance. This word is important in phase 4. Post-marketing surveillance. Okay. Is it helpful?
Yeah, it is.
Okay.
So only phase one, phase 0 and 1 are the ones that have small numbers.
numbers.
Two and three have big numbers, big amount of people, and then four is already post market, like after
So a
it's.
small, moderate, large, like small, medium, and large. If we
Mhm.
remember in that way, like phase one is small, then medium, then larger, and phase one, sorry, phase zero is like the pharmacology, like pharmacokinetic and pharmacodynamic property, and phase one is like safety, phase two efficacy, and phase three effectiveness between the current and the placebo, and phase four is the post marketing, like long term side effect.
Okay.
Okay.
Mm-hmm, mm-hmm.
Okay, so now I think that we can get it.
Okay. Okay.
So how I can find that
Mm.
this is phase one?
Well, we have a small number, it's 20 patients only. And then they are not comparing it with any. Wait, did they compare it with? No, they didn't compare it with another group. So it's only the people that are sick that are in the.
So 20 patient, one clue, and like there is no comparison. Okay,
Mhm.
okay. So it's safety. Do you want me to read the explanation again?
Yes, please. Oh,
Oh,
did you read it?
no, no.
Oh, no. Yeah, please. Can you read it?
Okay, novel treatments undergo rigorous testing prior to their introduction in clinical practice. The clinical trial described in the scenario is characteristics of phase 1 clinical trial. Phase 1 clinical trial. Phase 1 clinical trials are typically the phase 1 clinical trials are typically the first to involve the human subjects, following prior to preclinical research, often involving in vitro studies and animal models. Phase 1 clinical trials are primarily designed to assess the safety of a treatment rather than efficacy and involve small number of subjects. Because a small number of subjects are enrolled, phase 1 trials are powered to detect common or major safety issues, which and are not powered to detect rare adverse events. Ethical dilemmas may occur in the setting of phase 1 trials, which are designed to test the new drug or treatments that may or not be the safe. In this scenario, for example, patients with poor diagnosis, myocardial infarction with contraindication to surgery or anticoagulation may seek any available treatment out of the desire to experience a benefit in their participation in the study. Care must be taken during enrollment, provide informed consent, and ensure the participant understand that the goal of phase 1 trials to determine the safety and the benefits of the study are more likely to to science broadly rather than the individual patient. Okay.
Can you read BC? This
Yes.
one.
Effectiveness and efficacy are the similar terms that are typically assessed in later phase 2 or 3 clinical trials. Effectiveness and efficacy. Effectiveness 2, efficacy 3. Okay, provides efficacy describes the ability of the treatment to produce a desired effect in an ideal patient under ideal circumstances. In contrast, effectiveness describes the ability of the treatment to produce a desired effect in general patient population in real world setting, taking into consideration the conditions and the challenges of actual clinical practice. While these terms exist on a continuum, efficacy is generally assessed in patient in phase 2 clinical trial, which enroll hundreds of patients and are designed to determine how and why a treatment works, and if it has efficacy. Effectiveness is generally assessed in phase 3 clinical trials, which enroll larger numbers of effectiveness, typically thousands, and assess long-term effectiveness of treatment, often comparison in the current standard of care. The small number of participants described in the trial is consistent with phase 1 trial and would not be powered to show effectiveness or efficacy. Okay.
Can you, when you can, after when you can you take a picture of the thing to send it to me? The what you
We,
just shared.
oh yes, it's a first aid.
Increasing pain and swelling in her ankles. Her ankles are stiff in the morning and become progressively painful and swollen by the end of the work shift. She runs on a treadmill and lifts weight 3 times a week, but her symptoms have prevented her from running during the past month. There is no history of trauma and she has no other joint problems. Oh, yeah. She has hypothyroidism treated with levothyroxine. Exam of the ankle shows warm, moderate effusion. There is no redness. Active and passive range of motion of the ankles elicit pain. Remainder of the exam is fine. X-ray of the ankle shows no fractures or degenerative changes. Okay, which of the following is the most appropriate next step in diagnosis?
So what is your diagnosis?
Mm, definitely was not rheumatoid arthritis. I don't think it was that. Not that.
Why? Why?
I don't, because I'm used to rheumatoid arthritis, like it's bad in the morning and it gets better. But her is say that it gets worse by
Yes,
the
her
end.
ankle is stiff in the morning. This is a sign of rheumatoid arthritis, like morning stiffness, and become progressively painful, swollen by the end of her
So by the
work
end of
shift.
mm-hmm,
So actually, the RA actually progress. There is morning stiffness and there is swollen, painful finger. And is there anything active and passive range? Elicit mild pain. Okay, if you examine the patient of the hand of the rheumatoid arthritis, they will not gonna give you, because active and passive movement actually causes sore pain. Okay, but there is no joint destruction. Degenerative change means like osteoarthritis, and there is
mm-hmm.
no fracture. Okay, so it is RA. So RA anti-CCP antibody. If we can diagnose it, then it is easy. Okay, it's complicated. Okay, rheumatoid arthritis is an autoimmune disease that causes an extensive inflammation in the synovial tissue. The clinical course is characterized by joint destruction. It is not given here. The joint destruction,
Mm-hmm.
periarticular bone loss, synovial hypertrophy, along with extraarticular manifestations such as rheumatoid nodule, pulmonary fibrosis, skin rash patients often present with systemic involvement of multiple joints, most commonly the metacarpophalangeal joint and PIP joint of the hands, demonstrating articular erosion and progressive joint space narrowing on the X-ray. Al- um, ulnar deviation of the fingers with boutonniere and swan neck deformity commonly occurs. This patient presents with bilateral ankle pain and swelling without signs of OA. or degenerative changes shown on X-ray. Serology testing is the next step in the diagnosis. This testing includes serum rheumatoid factor, a sensitive test for rheumatoid arthritis, and anti-CCP antibody tests, a specific test used to diagnose rheumatoid arthritis. Treatment of rheumatoid arthritis include the use of non-steroidal anti-inflammatory drug such as ibuprofen and disease-modifying anti-rheumatic drugs such as methotrexate. Okay,
Okay. Next. 57 woman comes to the physician for routine gynae exam. 2 years ago, results of a CBC were within ranges, and her total cholesterol was 180, which I think is normal. She feels well. She has had 10-pound weight gain during the past 6 months. She takes no medication. Her last menstrual period was 4 years ago, and she doesn't smoke cigarettes. She drinks 2 glasses of wine daily. Temperature is fine, pulse fine, respiration fine. Blood pressure a bit high, I guess fine. BMI is fine. Physical exam shows mild atrophy of the vaginal mucosa. Serum studies. Okay, I have to open the thing. What is cholesterol? Total cholesterol was fine 2 years ago, and right now is high. HDL. It's high. HDL is normal. LDL is, what am I? High. Highlighted. So I'm getting, and then tags is dog is high, and then total bilirubin, I believe that's normal, and then alphos I think is normal too, and AST and ALT I believe they are normal too. Yeah. Which of the following is the most appropriate next steps to determine the cause of these patients' increased cholesterol concentration?
so
So
we know that hypothyroidism can cause hypercholesterolemia. So we need to measure the serum TSH. Okay, hypothyroidism classically presents with a combination of fatigue, weight gain, constipation, cold intolerance, and may cause heavy or irregular periods. Physician examination may disclose dry, edematous skin, bradycardia, and delayed relaxation of deep tendon reflex. In this patient, our symptoms are vague. Our symptoms are vague with just 4.5 kg of the weight gain, no other obvious changes, as the patient states that she feels well in the primary hypothyroidism with progressive decreases in the function of the thyroid, circulating concentration of the thyroxine and triiodothyronidine decrease. This results in feedback. This results in feedback of hypothalamus and anterior pituitary, leading to increased concentration of the thyrotropin releasing hormone TSH and prolactin. The increased TSH is measurable in serum and provides ongoing tropic stimulation to the thyroid gland. Increased prolactin may cause breast development, galactorrhea, and promote irregular anovulatory cycles or amenorrhea through feedback on gonadotropin releasing hormone. Another effect which is seen in this patient is the increase in serum cholesterol concentration. This occurs as a result of the low concentration of the thyroid hormone, which causes a decrease in the activity of HMG CoA reductase, the enzyme responsible for cholesterol synthesis. As a result, the body compensates for these decreased synthesis by increasing cholesterol absorption from the GIT. Additionally, hypothalamus can lead to production of low density lipoprotein receptors in the liver, further increasing serum cholesterol concentration. Include treatment includes supplementation with the levothyroxine and a few follow-up visit to evaluate for including therapeutic effectiveness, including monitoring of serum TSH concentration. Okay.
2-year-old boy brought who is in the hospital. A 2-year-old boy who's in the hospital has for apnea 12 hours after undergoing surgical drainage of the left hip because of sepsis. His medications are IV vancomycin, cefotaxime, and morphine. After application of back valve mass ventilation and administration of naloxone, um, the patient apnea resolves. Review of the patient of the hospital database shows that the patient morphine dose was too high. Which of the following is most likely to prevent recurrence of this type of error?
Okay, prevent the root case analysis. Perform root case analysis. This patient receives too much pain, too much opiate medication, too much opiate medication, but the underlying cause of this adverse event is unclear. To determine the factor contributing to this adverse event, the physician to conduct a root case analysis of the event. Root case analysis involves determining the core symptoms level issue that leads to the chain reaction of the events that culminate in the adverse event. There are several RCA strategies, including creating a timeline, surveying the controls in place that may have failed, and completing a risk tree analysis where the impact of each event is considered regardless of strategy. And typical RCA involves assembling a multidisciplinary team and meeting with this team regularly for a period. This team works to define and analyze the problem to design a set of corrective actions based on the analysis. Okay.
Okay. 57 men comes to the physician because he has cough up blood once weekly for the past month. He has had an intermittent mild cough for 10 years. He has a history of hypertension well controlled by lisinopril and hyperlipidemia by statin. He was treated for pneumonia 6 times during his 20s and 30s. He says he has had all the usual childhood disease. There is no family history of serious illness, no smoking. He works as a teacher aide. Temperature is fine, pulse is fine, respiration fine, BP, I guess fine, a bit high. Pulse oximetry or room air saturation is 99. Few crackles are heard at the lung basis. Grade 1 out of 6 systolic murmur best heard at the upper right sternal border. Okay. A CT scan of the chest is shown. Which of the following is the diagnosis?
Okay. Okay. In CT scan, it looks like bronchiectasis.
Mm-hmm.
Mm, okay, bronchiectasis refers to on X-ray. What we will find in bronchiectasis on X-ray?
Don't know. I don't remember. The dilated bronchioles? I don't know.
No, tram tract sign may be found.
Um,
L- Tram tract sign is like thickened, non-tapering bronchial wall and signet ring. These two thing can be found on X-ray. Tram tract sign or signet ring.
mm-hmm.
Okay. Mm, And on like this CT scan, there is presence of tram tract sign. Okay.
What do you see?
Sorry.
What is the contact sign on this CT scan?
Yes, on that CT scan. Tram
What is
tract.
it?
I just Google it and you will find the tram track sign. It
Okay.
it is like a like like a leaf. Okay, look at here. I can explain you this.
CT scan bronchiectasis.
like bronchial wall thickening with lack of distal tapering. There, that is tram tracking.
Okay, that thing.
Yes,
Yeah, when
like
it's
this bronchial wall is thickening with lack of distal tapering. Okay,
okay.
so this tram track sign is what can I say? This tram track sign is classical for bronchiectasis. So bronchiectasis refers to irreversible and abnormal dilatation and thickening of the bronchi, abnormal dilatation and thickening of the bronchi from recurrent necrotizing infection, from recurrent necrotizing infection and chronic inflammation, typically presents with frequent cough, excessive sputum production, and frequent respiratory exacerbation, narrow and obstructed airway resulting in wheezing on pulmonary auscultation, narrow and obstructed airway resulting in wheezing on pulmonary auscultation. They often have a history of recurrent episodes of pneumonia, childhood, and adolescent conditions associated with bronchitis include chronic bronchial obstruction, tobacco use, cystic fibrosis, primary immunodeficiency disorder, Carter-Jenner syndrome, situs inversus, Carter-Jenner syndrome, situs inversus occurring in association with primary dyskinesia, allergic bronchopulmonary aspergillosis. CT scan is used to confirm the diagnosis. Treatment is identification and treatment of underlying disorder, airway clearance technique, chest physiotherapy, expectorants, bronchodilator, and antibiotics for acute exacerbation. Okay.
mm-hmm. Previously healthy 8-year-old boy brought to the ED because of a 1 day history of increasing severe abdominal pain. He has no history of serious illness, no medication, and he appears well developed and well nourished. Temperature is high, pulse is high, BP low, cardiopulmonary exam shows no abnormalities, abdominal exam shows localized tenderness over the right lower quadrant. There is guarding at the McBurney point. Bowel signs are decreased. Lab studies show hemoglobin that is normal. Leukocyte count is high. Urinalysis shows no abnormalities. Which of the following is the most appropriate next step? Not appendicitis. Why did I choose that?
Okay. So appendicitis, ultrasound, operative intervention. Appendicitis refers to acute inflammation of the appendix, usually results in appendical obstruction by fecal lymphoid hyperplasia. Lymphoid hyperplasia leads to bacterial proliferation within the lumen and the wall of the appendix, within the lumen and the wall of the appendix, eventually leading to inflammation, infection, appendical necrosis, and perforation. Acute appendicitis typically presents with abdominal pain that is periumbilical at onset, may later to migrate to the right lower quadrant along with leukocytosis and tenderness to palpation. Bacterial proliferation causes leukocytosis such as this patient, which predominantly neutrophilic which predominantly neutrophilic. Patients often develop fever and may experience nausea and anorexia. When uncertain, the diagnosis can be confirmed with CT scan, MRI, or ultrasonography. Treatment involves IV antibiotic operative intervention, typically laparoscopic appendectomy to prevent appendical rupture, which can lead to peritoneal. If equivocal with negative imaging, serial abdominal examination are performed to evaluate for development of the condition. Okay, why operative then? Ultrasound can be done. Is
Oh,
it, sorry,
yeah, I had the same issue. If you read that one, it makes sense.
which one?
The, the AB, this one.
Okay, while CT scan of the abdomen can be helpful in diagnosing equivocal cases of appendicitis, it is associated with risk of radiation exposure, which is consideration especially in pediatric patients. Similarly, ultrasonography of the abdomen and the pelvis can confirm the diagnosis of the appendicitis. However, further confirmation of the diagnosis with a CT scan or ultrasonography should not delay the operative intervention in a patient with clear diagnosis of the appendicitis. No other source of fever with a negative urine analysis. No other source of fever with a negative urine analysis. So this patient presents with clear features of appendicitis and no clear competing diagnosis. The best next step is operative intervention. Measurement of C-reactive protein is used to detect an anti-inflammatory marker which potentially increase acute appendicitis. Is non-specific. It can be increased in a variety of the inflammatory condition. Measurement would not neither confirm to rule out the diagnosis of the appendicitis. While appendicitis is a clinical diagnosis, equivocal or uncertain cases be further be evaluated with imaging such as ultrasonography, CT scan, or MRI. Okay.
Makes makes sense now.
Yes.
Okay. Previously healthy 47-year-old woman comes to the physician because 5-day history of an itchy rash. The rash initially began on her trunk but now has spread to her face, arms, and legs. No fever, shortness of breath, fatigue, loss of appetite were thought. She returned from a trip to Jamaica 2 days ago. Wait, and the rash started 5 days. Okay. She takes some medication and has no known drug allergy. She has had peanut allergy since childhood and typically has shortness of breath and swelling of the lips when she eats peanuts. She does not recall ingesting peanuts on her trip but says that she ate food at the hotel. Temperature is fine, pulse is fine, respiration fine, BP is fine too. Exam shows no abnormality except for 1 to 2 centimeters circular blanch raised urticarial lesion over the face, trunk, and upper and lower extremity. The rash is most prominent over the face, hands, and feet. Which of the following is the most appropriate next step?
So it is urticaria, isn't it? So for
Mm,
urticaria, antihistamine is the choice. Do you want me to read the explanation?
yes, please.
Okay. Urticaria or hives is caused by the type 1 hypersensitivity, reaction, or type 1 hypersensitivity reaction to an environmental, type 1 hypersensitivity reaction to an environmental or food allergen. Inciting allergens results in the cross-linking of preformed IgE on the surface of the basophil and mast cell, leading to their immediate degranulation and release of the histamine. Immediate degranulation and the release of histamine, prostaglandin, leukotrienes, which results in vasodilation, vascular pooling, and increased vascular permeability. Type 1 hypersensitivity reaction may present with symptoms ranging from localized pruritus, edema, erythema to widespread arterial rashes, as in this patient, to systemic life-threatening anaphylaxis. Other examples include allergic asthma, atopic rhinitis, and atopic dermatitis. Skin testing can be performed to identify specific allergen. Treatment includes removal or avoidance. Includes removal or avoidance of offending allergen if known, and administration of H1 antihistamine. Both first generation diphenhydramine and hydroxyzine and second generation fexofenadine cetirizine H1 antihistamine may be used. Okay.
Okay. 7-year-old boy brought to the office by his mom because she's concerned about his behavior at school since he began second grade 3 months ago. His teacher said he often fidgets and talks to his classmates when he has been told to be quiet. He misbehaves in language, art, and spelling class, but is well behaved during math and science class. He has been sent to the principal office 3 times during the past month because of disruptive behavior. He says recess is his favorite part of school. He likes reading. His mother has no concern about her son's behavior at home. She says he has many friends in the neighborhood and enjoys sports activity. He has no history of serious illness, doesn't take medication. His paternal cousin has ADHD. Patient father dropped out of high school in 10th grade because of difficulty reading. During the exam, the patient is talkative and tells the physician about his new bicycle. Vital signs normal. Exam shows mild eye blinking motor tic. His mother says that the tic has occurred intermittently during the past 2 weeks. No other abnormalities. What is the diagnosis?
What is your diagnosis?
Dyslexia.
Dyslexia. You know how to diagnose it. Okay. Dyslexia is a term used to describe a specific learning. Dyslexia is used to describe as specific learning disorder, disability of reading or reading difficulty, or difficulty of reading or reading difficulty. It is caused by cognitive deficit in phonologic processing, cognitive deficit in phonologic processing. I lost.
Oh, what's your
Sorry, yes. Dyslexia is diagnosed. I'm sorry. Phonologic processing dyslexia is diagnosed by physician or educators through an assessment of fluency, decoding, and comprehension. It may ultimately lead to decreased vocabulary and general knowledge, reducing the likelihood for educational achievement. A family history of reading difficulty, prematurity, poverty, neurodevelopment conditions, ADHD, prenatal alcohol exposure are risk factors. These patients are experiencing challenges specific to classes to involve in reading which are consistent with dyslexia. Many young patients with dyslexia act out in response to their frustration with reading tasks. Treatment involves educational intervention to improve literacy and reading comprehension. Okay,
okay? So dyslexia is issues with reading only.
yes.
Okay.
Then why it is not specific learning disorder, like specific reading or learn? There is a term in the first aid.
Mm-hmm.
You,
Hello. You
yes,
still there?
yes, I'm
Okay.
there.
Mm-hmm. You
So
say why
I,
it's not specific
yes, why
learning
it is
disorder?
not specific learning disorder?
I don't know. I mean, it's not an option here. I don't think they will give you uh, dyslexia and specific learning disorder both in the same question.
Like in
Because
the first aid, there is an option like specific learning disorder.
yeah, I know there is that option too, but it will be really confusing if they give you both of them. Because I feel
Yes.
like dyslexia can be a type of specific learning disorder. So it will
Okay.
be
Yes,
confusing.
that
Yeah,
makes sense.
yeah, it will be confusing if they give you both on the same question. It wouldn't make sense because it can be either or.
Yes, that fits.
Okay, 42 woman gravida two para two comes to the office because of a 1 day history of loss of clear yellow vaginal fluid while walking. Okay, she has sucked two absorbent pads during this time. 2 weeks ago, she underwent laparoscopic assisted total vaginal hysterectomy for menorrhagia, dysmenorrhea, and adenomyosis. Intraoperative dissection of the bladder from the cervix was complicated by. Okay, wait. Intraoperatively, dissection of the bladder from the cervix was complicated by adhesions. Okay. She has mild asthma treated with albuterol inhaler 3 to 4 times monthly. Both her pregnancies ended in low transverse cesarean deliveries because of breech presentation. She has been taking ibuprofen 4 times daily and reports good pain control. Temperature is high, pulse is normal, respiration normal, BP normal. On exam, the abdomen is not distended and untended. There is no blood over the perineum. Which of the following is the most likely cause of the patient's current condition? Yeah, that makes sense.
Okay, this patient this patient has likely sustained a bladder injury in the form of VVF, vesicovaginal fistula, resulting from her vaginal hysterectomy. Complication related to adhesion between the bladder and the cervix. VVF can be a consequence of gynecological surgery, pelvic pathology, and inflammation or radiation therapy. It occurs when a tract opens between the bladder. When a tract opens between the bladder and the vaginal wall, results in painless, usually asymptomatic urinary leakage, from the vagina, as seen in this patient. Although it is although it is usually asymptomatic and it does not increase the patient's risk from cystitis from vaginal flora. A genitourinary examination can show a pool of urine in the vaginal canal. The site of fistulization may be too small or difficult to visualize. Confirmatory testing entails infusing dyed sterile fluid into the bladder, then evaluating the vagina for the presence of transmitted dye. The treatment of a VVF involves surgical repair.
Next, an asymptomatic 72-year-old woman comes for follow-up exam after she was found to have 80% stenosis of the right internal carotid artery. A new study has shown that endarterectomy of asymptomatic stenosis decreases the risk for stroke or death from 10% to 5% at 5 years. Okay, and it's significantly whatever. Um,
Is it
indicate
number
that.
needed to treat or number needed to harm?
Wait, which of the phone is the best way to Okay,
Okay,
um,
you explain.
I don't know.
When the biostat comes,
I
start
don't,
explaining.
I don't know this one. I got it wrong. I don't
It's
know.
not a problem. You read and you make me understand. These things actually kills my brain actually. Okay, why
Okay.
it is the answer? Like number needed to treat divided by absolute risk reduction, ARR, isn't it?
Mm-hmm, mm-hmm,
And number needed to harm is one divided by absolute risk, ARI, or AR, attributable risk.
mm-hmm,
Okay, and the ARR is like risk of exposed minus unexposed. So how we can calculate or how we can get the answer?
I don't know. Did they just calculated everything? I don't know. Okay, you can read.
If I read it the whole night, I am not able to understand. Okay.
Understand.
Number needed to treat is an epidemiological measure used to characterize the intervention that clarifies the effectiveness of the intervention. The effectiveness of the intervention. The number needed to treat is the number of the patient who must receive an intervention in order to prevent the occurrence of one negative outcome. In this example, the risk of death is reduced by endarterectomy 10 to 5% at 5 years. 10 to 5% at 5 years. The difference between the two rates is 5%. Describes an absolute risk reduction, which are defined as risk reduction. Okay, which are defined as the difference of the rate of adverse outcome between the treatment and the control groups of the study. Number needed to treat is the inverse of ARR and can be derived by the equation number needed to treat 1 by ARR. In this example, 5%. Okay, now I got it. A
You
number,
got it.
yes. The number needed to treat is 1 by 5% means 0.05. Okay, that means 20. Okay,
Wait, can you read the other
with
ones?
other options.
Yeah.
Okay,
Sorry.
endarterectomy decreases the absolute risk for stroke or death by 50%. Is incorrect. The answer corresponds instead of relative risk reduction. To define relative risk reduction, relative risk must relative risk must be defined. Relative risk describes the difference in relative likelihood of the occurrence of a particular disease outcome between the two groups of patients with or without particular exposure. Relative risk reduction is the proportion of risk reduction that can be attributed to the intervention compared to the control and is defined as relative risk reduction 1 by RR. In this example, the risk of stroke is 10%. The risk of stroke or death from 10% is untreated patient and compared to treated 5% who receive endarterectomy. So therefore 0.05 to 0.15 50%. So RR is 1 minus 0.05 is 0.5 50%. So relative risk reduction is 50%.
Mm-hmm. Okay. You read C and F. I mean, these two, the last two.
Okay. Endarterectomy prevents the 5% of the strokes or deaths is incorrect. Interpretation of the result. Endarterectomy reduces the rates of stroke or death among patients from 10% to 5%, if therefore resulting in prevention of half of all strokes or deaths or reduction 50%. There is another way for describing RRR. I don't get it. This one.
I think here is just knowing how to calculate RRR and RR. If you get it, then you will get to 50%, and you will know that okay, it's RRR. That's 50%. It's not, it's not 5%. But I don't remember how to. I don't remember how to calculate the R. Like, I had to figure out how to calculate the RR and RR. I don't remember how to do that. So
Okay,
yeah.
next.
Yeah. An otherwise healthy 17-year-old girl is brought to the physician by her mother because of a 1 year history of monthly cramps. 1 year. Okay, that began 3 days before the onset of menses and lasts 5 days. Okay, cramps. The cramps have increased in severity during the past 4 months, causing her to miss like 1 2 days of school each month. Menses occur at regular 30-day intervals and last like 4 to 5 days. Menarche was at 14. She has never been sexually active. BMI is fine. Exam shows, wait, she's 5'5", and BMI is fine. Exam shows a non-tender abdomen and normal external genitalia. Um, Pelvic exam is limited because of narrow vaginal equators. Ultrasound of the pelvis shows a normal uterus and ovary. Which of the following is the most appropriate next step in management? Hmm,
Is it endometriosis?
That's what I thought, but it doesn't look like it. Nope,
Oh no, it's
doesn't
primary
look like it.
dysmenorrhea. So primary dysmenorrhea or painful menstruation. Primary dysmenorrhea or painful menstruation is defined as the pain that accompanies each menstrual cycle but is not associated with any underlying pathology. It is common cause of cyclic pelvic pain in healthy patient assigned female at birth. Patients describe cramping, lower abdominal pain, or pelvic pain that begins several days prior to the onset of the mens, which persists for several days along with fatigue, nausea, vomiting, pre-syncope, and/or headache. Symptoms often begin during adolescence and commonly interfere with the quality of the life and essential activities such as school or work. To diagnose primary dysmenorrhea, the causes of second the causes of secondary dysmenorrhea must be ruled out. These may include endometriosis, leiomyoma uteri, adhesion, PID, cervical stenosis, adenomyosis. Many of these can be reasonably assessed on the pelvic examination, pelvic ultrasonography, which in this case did not show any characteristics abnormal. The primary dysmenorrhea is attributed to painful uterine contraction and pain and uterine vasoconstriction in response to increased prostaglandin production by the sloughing endometrium. Thus, treatment targets this pathway with medication including NSAIDs, topical heat therapy, oral contraceptive, and uh, a progestin IV may also be used to regulate the symptoms if persistent. Thus, the most appropriate next step in the management of this patient with primary dysmenorrhea is the initial primary dysmenorrhea is the initiation of oral contraceptive therapy.
You read B and C.
Yes, CT scan of the pelvis. CT scan of the pelvis can be CT scan of the pelvis can be used to evaluate for a variety of the causes of cyclical abdominal pain such as leiomyoma uteri, adenomyosis. However, these causes of abdominal pelvic pain are typically also evaluated by the ultrasonography, the findings of which were normal in this patient. A normal CT scan is unlikely to provide additional information on which to base this patient's diagnosis of primary dysmenorrhea and would expose her to unnecessary radiation if the diagnosis were unclear or if were conflicting clinical evidence. A CT scan may be appropriate.
Okay.
Okay.
Next.
Yes.
87 men transferred to the ED from a skilled nurse care facility because of progressive confusion during the past 3 weeks. He underwent resection of a lung cancer 25 years ago and has a history of DVT. His only medication is warfarin. On arrival, he's not sure where he is or why he is in the ED. Vital signs normal. Exam shows multiple small abrasion and ecchymosis over the body. Pupils are 4, so I think normal, and reacts slowly but symmetrically to stimuli, to light. There is a slight drift to the right upper extremity when the patient holds both upper extremities in front of him. He is unable to perform Series 7. Which of the following is the most appropriate next step in diagnosis?
So, what is your diagnosis?
Some kind of upper motor neuron issue, because he cannot with that sign, that test of holding the arms up and then one drifts.
Like pronator drift?
Yeah, it's upper motor neuron, right?
Yes.
Issue. Oh, no, yeah, yeah. Mm,
Okay. CT scan of the head is the first step in screening of the subdural hematoma. On imaging, a crescent shaped collection abutting the internal surface of the skull, not bound by the suture line. Head trauma, the use of anticoagulant, physical abuse, alcohol use disorder, age-related cerebral atrophy, and malignancy are associated with increased risk for developing SDH. This patient poses many of these risk factors. Elderly patients are at risk of cerebral atrophy, which places traction on bridging cortical veins. In this setting, minor trauma such as falls can result in shearing of the veins, leading to hemorrhage. In some cases, subdural hematoma may be large enough to compress adjacent brain parenchyma. The displacement of the cerebral hemisphere can result in neurologic deficit, confusion, seizure, herniation syndrome, and signs of increased intracranial pressure. Those symptoms onset may be acute, and initially small subdural hematoma may grow over time, resulting in gradually progressive symptoms as seen in these patients. Patients may manifest findings on neurologic examination consistent with upper motor neuron lesions such as pronator drift, spasticity, hyperreflexia, and present Babinski sign. The intracranial compartment is fixed space within the rigid skull. Pathologic lesions such as subdural hematoma can result in midline shift and herniation of the central nervous system structure if large enough. When mass effect is present or at risk for developing, surgical intervention such as decompressive bar hole or craniotomy may be indicated to evacuate the hematoma. Okay.
okay. Next. 52 woman comes to the office for a 6-month health evaluation. Okay. She has felt generally healthy, medical history, hypertension, and mild arthritis. She takes thiazide and acetaminophen as needed. No smoke or alcohol. Vital signs normal. Boop, 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 boop. Yeah. Physical exam discloses no abnormality except for loss of her arch when standing. An arch is present when she stands on her toes. Huh. There is also more eversion. of the heels than normal when standing, and mild swelling over the lateral aspect of the ankles bilaterally. Which of the following is the most appropriate diagnostic study? What is happening? Sure, so much going on. Mhm.
What is your diagnosis?
I do not know what that. I thought it was something to do with diabetes, but then I look and she doesn't have no diabetes. I'm like, okay, I do not know what's happening. Okay, so this is flat face planners. Okay, I guess.
Okay, this is the I think that it is one clue. Like physical examination discloses no abnormalities except for loss of arch when standing. In flat foot, when you stand, there is loss of arch, medial arch. In normally, if we stand, there is an arch, medial arch. If there is loss of arch when standing, an arch is present when stands on the toe.
Mhm.
So arch, an arch is present when it stands on the toe. So if that is the thing, okay, it is clinical diagnosis. Arch foot, okay, pace planus. Very important. Flat foot, mm, flat foot or pace planus, a common finding on physical examination. Flat foot or pace planus, a common finding on physical examination, characterized by loss of medial longitudinal arch as well as heel eversion. Heel eversion, inversion, as well as heel eversion. This condition may be congenital or it can be acquired through trauma, long-standing diabetes, and injury to the posterior tibial tendon. Flexible flat foot as seen in this example in which when the loss of medial longitudinal arch when loss of medial longitudinal arch only occurs when standing, with the arch returning after lifting the foot on heel. Flat foot is often asymptomatic but can be alter biomechanics and produce pain in some patients. Imaging is not routinely required in the evaluation of the flat foot in the absence of trauma or reported symptoms. When patients are asymptomatic, initial management include orthotics, NSAIDs, activity modification. No additional diagnostic indicated as seen in this patient and has not need any symptom or reported recent trauma of the ankle. Okay.
You read A.
Yes. CT scan of the feet used to evaluate the bone or soft tissue pathology. This patient physical examination shows a non-specific finding, mild ankle swelling that does not require further workup and advanced imaging studies. If advanced imaging were required, MRI would be preferred in the absence of the contraindications such as metal fragments or the presence of incompatible pacemaker or mm, implanted device. Okay. Oh,
Next. 80-year-old woman comes to the physician because of two episodes of vision loss in her right eye that occurred yesterday. Each episode lasted like 3 to 5 minutes. She also has 6 month history of frontal headache, fatigue, and aching in her right arm with exertion. She is otherwise fine. She has hypertension and osteoporosis. Medication, metropolo, lisinopril, alendronate, and calcium supplementation. She does not appear to be in distress. Pulse is fine, BP fine in the right upper extremity, and super high. BP is super high in the left upper extremity. Um, okay. Ophthalmologic and fundoscopic exam is fine. Peripheral pulses are 2 plus. Neurologic exam is fine. ESR is, I believe that is high. I will check. Carotid Doppler ultrasound shows stenosis of 20% to 40% of the right carotid artery and of more than 50% of the right subclavian artery. Which of the following is the most appropriate next step in management? Wait, ESR is.
What is your diagnosis?
I was gonna say the amaurosis fugax, but I guess it's not that.
No. Age more than 50 years or more than 50, there is headache. Uh,
Oh, temporal arteritis.
yes, it is
Okay.
temporal arteritis or giant cell arteritis. And
Oh,
we know that in temporal arteritis, there is carotid artery stenosis. So that's why carotid duplex ultrasonography is done and there is stenosis. So in temporal arteritis, we will give high dose steroid.
can you read the?
Yes, yes. I am saying what I remember.
Yeah. Okay.
Okay, that's why. This patient symptoms are transient monocular and temporal arteritis associated with amaurosis fugax.
Oh, okay,
And
okay.
AION also can happen. Acute
Mhm.
ischemic optic neuropathy in temporal arteritis. Okay. Okay. This patient symptoms this patient symptoms transient monocular vision loss. This patient symptoms transient vision loss, headache, fatigue, proximal extremity weakness are consistent with temporal arteritis. Temporal arteritis is an autoimmune inflammatory vasculitis of the medium and large vessel vasculitis. One temporal arteritis is suspected. Once temporal arteritis is suspected, mm, treatment with high dose corticosteroid such as prednisolone occur immediately to prevent the vision. To prevent the vision. And classic symptoms include, and if, like, I want to add one thing, like if a patient with giant cell arteritis with a vision loss, then we should give pulse high dose IV glucocorticoid. It is written on the inner circle, pulse high dose IV glucocorticoid like methylprednisolone, 1000 milligram for 3 days, followed by that 40 to 60 milligram of glucocorticoid, like high dose glucocorticoid, if there is vision loss. Okay.
Mhm.
Classic symptoms include fever, chills, weight loss, headache, history of preceding transient vision loss, amaurosis fugax, jaw claudication, tenderness on the scalp, and pale optic disc edema. Temporal arteritis most commonly affects the vessels of the head and the neck, the ophthalmic artery, particularly the ophthalmic artery, and inflammatory occlusion, which can result in sudden ischemic damage of the the retina. Once vision loss occurs, it is irreversible. Once vision loss occurs, it is irreversible and commonly followed by vision loss is contralateral eye within days to weeks. Notable ophthalmic examination may detect no abnormalities before irreversible arterial occlusion has occurred. New onset new onset headache in an elderly patient should raise new onset headache. An elderly patient should raise suspicion of temporal arteritis. Frequently occurs in association with polymyalgia rheumatica, which is a characterized stiffness of the muscles, as occurs in this case. Lab studies, thrombocytosis, increased inflammatory marker, ESR, CRP, duplex ultrasonography show reduced flow within the inflamed vessel. Okay, the diagnosis is confirmed with biopsy of the temporal artery showing granulomatous vasculitis. Corticosteroid does not generally compromise biopsy result if the biopsy is performed within 1 to 2 weeks. So biopsy should be performed within 1 to 2 weeks.
Okay. Next. 91 man brought to the ED by his wife because he collapsed at home after the onset of a headache. He has COPD and claudication of his lower extremity. He underwent removal of bilateral cataracts 5 years ago. Medications, metoprolol and albuterol inhaler. He has advanced directive stating that he does not want any heroic life prolonging measure. He's intubated and mechanically ventilated. He's unresponsive to stimuli. Approximately 10 minutes after arrival, the cardiac monitoring confirms the systole. Which of the following is the most appropriate next step in management?
Okay, so cardiopulmonary informed the patient's wife as he was died. Okay, cardiopulmonary resuscitation attempts to reverse clinical death, which, in combination with cardiac arrest and cessation of respiratory drive before brain death occurs, typically approximately 5 minutes of cardiopulmonary collapse, and is enough to lead to brain death. According to American Academy of the Neurology, of the brain death is permanent loss of the brainstem function. Brain death commonly occurs after an acute catastrophic brain injury secondary to intracranial trauma, cardiovascular collapse, and or intracranial hemorrhage. Brain death can be diagnosed by neurologic examination showing absent cranial nerve reflex and lack of showing absent cranial nerve reflex or lack of painful stimuli, and an apnea test showing absence of respiratory drive. This patient does not respond to painful stimuli, making brain death likely. Patient do not the patient has do not attempt DNR order. In a patient without the advance directive that involves DNR order, CPR may be attempted immediately after the onset of the asystole, particularly with brain death is not already evident. However, this patient's advance directive precludes the use of CPR. Signs of brain death mean that CPR is likely to be futile. Brain death constitutes of legal death, and this patient's wife should be informed that he has died.
Okay. Next. 45 men comes to the physician for annual follow-up. 47, no, sorry, 57. He has hypertension, hyperlipidemia, hypercholesterolemia. He has had no claudication or chest pain. Current medications, atenolol, simvastatin. The Lisinopril, he has smoked for like 40 years. He BMI is fine, temperature fine, pulse fine, respiration fine. BP is fine. Pedal pulses are absent on the right. There is no tenderness. The right ankle brachial index is low, zero point 0.8, and the left ankle brachial index is fine. I guess one. ECG shows normal sinus rhythm and borderline left ventricular hypertrophy. Labs A1C is 6.5. I think that's fine, right? Yeah. Urea at 12, glucose is fine. Urea, I think is fine. Creatinine, fine. Cholesterol, oh, I forgot again. Where is it? Where is the cholesterol? Cholesterol is fine. HDL is fine and LDL is fine. In addition to recommending smoking cessation, which of the following is the most appropriate next step? Hmm.
Okay, this patient with absent pedal pulses on the right and ankle brachial index of zero point 0.8 has presentation consistent with peripheral vascular disease. Peripheral vascular disease is common among older male smoker with a history of hypertension, diabetes, hyperlipidemia. The diagnosis is suggested by absent or diminished peripheral pulses, legs, hairless legs with small, smooth skin that may ulcerate, and is further supported by the reduced ankle brachial index. The ankle brachial index is a non-invasive means of assessing peripheral vascular disease and can be performed in the clinic. It is commonly calculated by the dividing It is commonly calculated by dividing the systolic blood pressure in the lower extremity, systolic blood pressure of the lower extremity at the ankle, mm, by the systolic blood pressure in the arm at the level of the brachial artery. A ratio a ratio of less than zero point 0.9 indicates the presence of occlusive arterial vascular disease, while a ratio between zero point 0.9 to 1.3 suggests normal arteries. And ankle brachial index above 1.3 likely indicates the presence of calcified vessels and necessitates further evaluation for vascular disease. All patients with confirmed PVD should be started on a statin and antiplatelet agent such as aspirin for secondary prevention of coronary artery disease. Exercise programs are often effective in improving exercise tolerance, increasing neovascularization and control lateral flow, and diminish symptoms. Okay.
Okay. Next. Comatose 2-year-old boy brought to the ED by paramedics after his parents found him submerged in the family swimming pool for an unknown length of time. Cardiopulmonary resuscitation at the scene was initiated by neighbors and continued by paramedics en route to the hospital. After a total of 20 minutes of CPR, a normal sinus rhythm is established. On arrival, the patient remains comatose, he is intubated, and mechanical ventilation is started. At this time, arterial blood gas analysis on FiO2 of zero point 0.6 shows pH is acidic, PCO2 is normal, and PO2 is high. Okay. His serum sodium concentration is fine, I believe. Yeah, a bit low, fine. This patient is at greater risk for which of the following complication during the next 48 hours?
Okay. It's a RDS. Drowning in children can result in variety of the clinical presentation depending on the severity of the non-fatal drowning event. Patients can present with aspiration, hypoxemia, respiratory distress, laryngospasm. Hypoxemia can lead to ischemic neuronal damage, resulting in cerebral edema. Results in cerebral edema during a drowning event. Aspirated fluid causes local inflammation in the lung along with the dilution of the surfactant, leading to the impaired compliance and airspace infiltration. This can result in persistent and severe hypoxia despite management with positive end expiratory pressure and increased fraction of inspired oxygen. Prolonged hypoxia leads to end organ dysfunction leading including acidosis, hypoxic brain injury, cardiac arrhythmia damage to the alveoli with resulting inflammation can lead to development of acute respiratory distress syndrome, which appears as chest X-ray as non-cardiogenic pulmonary edema. This patient is this patient is at increased risk for mm, this patient is an increased risk for developing ARDS in 48 hours following the drowning event. Intubation and management of hypoxia is an appropriate for patients with severe respiratory distress. Hypoxia and hypercarbic respiratory failure, unresponsive to non-invasive measures, neurologic deterioration, cardiac arrest. Adequate management of hypoxia decrease the risk further complication of the hypoxic brain injury. Okay, in this type of question, I am bit confused about. I'm bit confused in between the ARDS and pulmonary embolism. How can I differentiate?
What do you mean?
Like why it is not pulmonary embolism?
But why would the drowning cause the pulmonary embolism? Can it cause pulmonary embolism, the drowning?
Mm,
Because here they're talking
mm,
about the child that drowned. So what would be
yes,
the risk
childs are
factor?
drowning.
What would be the risk
Like
factor?
long travel, prolonged hospitalization can, malignancy can, drowning usually do not.
Yeah, because here there is no risk factor for pulmonary embolism. Or you mean did you find another question that had both pulmonary embolism and ARDS?
Yes.
Okay.
So how can we differentiate like PE and ARDS if you keep this into side by side?
Mm, I know I never found the question. I don't remember finding the question. But can you read D? Then choice D.
D is clear in here, like presence with shortness of breath, chest pain, tachypnea, uh, though the presentation varies along a spectrum. Patients with exhibit intact breath sound throughout the lung. Common risk factors include hypercoagulation, malignancy, history of immobility, long travel, prolonged hospitalization. The most common ECG is sinus tachycardia. A pulmonary embolism after a drowning event is unlikely.
I guess the chest pain, because does ARDS has chest pain?
Yes,
Yeah,
ARDS can have chest pain.
it has chest pain. Okay. Mm, I don't know. I never found this.
ARDS kind of similar. In here there is drowning, but there are some questions where there is ARDS and PE in the question stem. That one
And
is
then
difficult.
I will assume the ARDS because it's water in the lungs, it will have like crackles, and then the PE it will have like no sounds or wheezing or something like that, but it won't have
Yes,
crackles.
PE can come with
Mhm.
the clear lung.
Yeah, the clear lungs and breathe. But here ARDS, I assume because it's like liquid in the lungs, you will have like crackles and things like that. I am assuming. I'm assuming. I don't know.
On the like in the question stem, they haven't say about the crackles.
Yeah, yeah. I think here is pretty clear that it's not PE in this specific question because there's
Okay,
a kid.
if I find this
Yeah,
type of
if you find
difficult
that
question, then I
question,
will keep the
yeah,
number.
yeah, please, if you do, yeah.
Okay,
Okay, we are done.
done.
I think that was the last section, right?